Okay, here we go. We're going to get started on thyroid disorders, which is chapter 58 in your textbook, so make sure that you go through that, highlight, read it, summarize it, things like that. So we're going to go through some things here. The first thing is it's always good to bring faith into our learning while we are Lutheran University, but not only that, God is the one that we should look to for everything in our life. If you have a problem, go to the Bible. There's always an answer there. So this is a good psalm. It's 107, 19 to 21. Then they cried to the Lord in their trouble, and he saved them from their distress. He sent forth his word and healed them. He rescued them from the grave. Let them give thanks to the Lord for his unfailing love and his wonderful deeds for men. So this could have something to do with our patients being ill in the hospital, as well as for all of you as you're going through these courses, right? So the Lord will help save you from your distress. All right, so let's go over some thyroid physiology. I'm only going over thyroid physiology. When you think of the thyroid, just like diabetes, it's the endocrine system. And the endocrine system is very intricate with multiple hormones, approximately 8 hormones that are in the endocrine system. And it's a continuous cycle. If one's not working, if one hormone's not working or releasing correctly, then the next hormone's not going to work. And so then you have some dysfunction, malfunction. Another part of endocrine system is your reproductive organs. So that has testosterone, androgens, estrogen, that kind of thing. So we talked about diabetes already with the endocrine system as far as your insulin levels, but now we're going to talk about thyroid. So when you think thyroid, think first of all, where is your thyroid? It's right here in your neck, right? So you should know that by now, that it's right in here. It's like a little butterfly shaped thing. And your pituitary gland in your brain, that's like deep in the brain, anterior pituitary gland is what releases TSH, which is thyroid stimulating hormone. If you go one step behind that, you have a hypothalamus that's releasing a thyroid releasing hormone, TRH. Okay, so it's all part of a cycle. You have the thyroid releasing hormone. And so what that's doing is sending a message to the anterior pituitary gland. The anterior pituitary gland is basically reading what the thyroid's doing. So if the thyroid is working okay, then the pituitary gland is going to excrete the normal amount of thyroid stimulating hormone it needs to. So think of TSH as it's stimulating the thyroid. All right, so if it's working properly, it's going to release the amount it needs to release. So when you get your blood drawn, a TSH drawn, it's within the normal range. Okay, so what happens is in your thyroid, you have 2 thyroid hormones, and T4 is a significant thyroid hormone as it's basically only produced in the thyroid. All right, so it's called a T4, produced in the thyroid. Then you have T3. T3 is also produced in the thyroid, but it's also in other areas of the body. So a really good indicator to see if, number one, you have hypothyroidism or hyperthyroidism is to get a thyroid stimulating hormone and a T4, because we know that if that's not functioning, if that's low or high, then we know there's a problem with the thyroid. Sometimes with the T3, it could be other areas of your body. So if you look at this graph here, you see T3 and T4, it's the arrow's going this way back up here to the pituitary gland and the hypothalamus, because it's sending messages to say, hey, all right, excrete the hormone. Yes, let's excrete this thyroid stimulating hormone. Stimulate, let's wake it up, let's wake it up. All right, or let's shut down. That's the other thing. You can shut it down because it's too hyperactive. So let's just use an example here. All right, so, and I'll explain this in class more too, because the thyroid can be a little confusing here, because if one is elevated, it actually means you're hypo. So let's just say that your thyroid decides, you know, it's not going to work as well. It starts dysfunctioning, and a lot of times we don't really even know the reason why it starts dysfunctioning. It could be a genetic disorder. It's just hard to say why. We really don't have a lot of data out there. let's just say this decides to stop working. Well, that means that it's going to stop or slow down the production of T4. So the T4 is going to go low. Your T3 is going to go low. So when it's sending messages up here, it's not producing enough. So it's only producing a smaller amount. So that's going to tell your hypothalamus and your pituitary, wow, we better wake up this thyroid. So you're going to see excessive amounts of TSH going into the thyroid to try to wake it up. All right? Because it's saying, wow, there's not enough thyroid T4 going up here, so we need to stimulate it to wake it up so it'll produce more. Okay, so when you get your labs done and you have a high TSH and your T4 is low, that's telling me you have a hypothyroid because your thyroid's not working well. So that's why the TSH is high, because it's trying to wake it up. The opposite would be true for hyperthyroidism. Say this becomes overactive. It can become overactive because of a nodule, cancer, a genetic disorder, etc. Hypo can also be from nodules too, which we'll talk further about. But let's just say, for example, this decides to become overactive. Well, then you're going to pump out more than enough T4 and T3. Goes up here, and what's your pituitary and hypothalamus going to do? Especially your anterior pituitary. It's going to say, all right, it's working. I don't need to put out so much TSH because there's enough T3 and T4, so it doesn't need to stimulate it to wake it up, right? So then when you get your labs drawn, your TSH is going to be low because it doesn't need to wake it up. It's already awake. It's hyperactive. All right, so I hope you kind of understand that, and I'll explain it further in class if you have any questions. Sorry about that. All right, so thyroid hormones. Think of it having to do with basically your entire metabolism and your function of your entire body. It's very important. Cardiac function, your growth, development. That's why it's really, you have to be real careful and make sure that you treat it. So we have the serum thyroid stimulating hormone, which we just talked about, the TSH, and it's good for diagnosis of hypothyroidism. Now we say screening, but in real life, the guidelines is we don't screen for this. We don't screen for hypothyroidism because the reason why we do screening tests is, number one, is money, because it actually costs more money sometimes not to screen, or it costs more money to screen. So for example, early detection of breast cancer, we do screen with mammograms because we found out, number one, early detection is important, but number two, the cost of treating breast cancer is astronomical, and we found more benefits to doing early detection, and we can catch them early, and so that way the treatment won't be as much money. Unfortunately, it goes down to that too, as well as research and early detection. But there is no screening for hypothyroidism. When people come in with symptoms, we will draw their blood and check for the TSH. Elevated TSH is hypo, so up, down, it's not working. Serum T4 test can measure the total free T4 and a total free T3. So when you're getting these tests, you order a serum free T4 and a T3. It's rare that we get a free T3. It's actually a T3. So we'll get the TSH, a free T4, and a T3. So remember I said hypothyroidism basically is in charge of your entire metabolism in your body. So think about all the symptoms you can have, which is why we don't do screening also, because pretty much most of the time, most of my patients come in and they say they're tired. A lot of people are tired. Some people will have hair loss. Some people will have some weight gain. And so it's very easy to go ahead and get a TSH. It's a fairly inexpensive test. It's done so often because the insurance will pay for it as long as you have a symptom. So intolerance to cold, think of hypothyroidism as being things are not functioning. So you're kind of like, you're tired and you're just not feeling good. You start having brittle nails, your hair's falling out. Some people get a thick tongue, although I would say the most common symptoms are tiredness, dry skin, constipation because things are slowing down, bradycardia, weight gain. If you have a decreased level of consciousness, that's dangerous, and you're going towards a thyroid storm, it's called, which it's too low, and you need to be in the hospital, and they need to give you IV levothyroxine to get that thyroid working again. Levothyroxine we'll talk about, because obviously it's pharmacology, but it's a synthetic form of your thyroid hormone. So look over these symptoms on here. So we're going to talk about hypothyroidism first. Cause is usually due to malfunction of the thyroid. Well, yeah, that would be an obvious, right? One reason would be Hashimoto's disease, which is a chronic autoimmune thyroiditis. So this is an autoimmune disease, again, one of those genetic markers. And when you think of thyroiditis, break up the word. Itis means inflammation, thyroid is thyroid, so inflammation of the thyroid. If you have a surgical removal of the thyroid and destruction of the thyroid with radioactive iodine, then you become hypothyroid. So you need to take replacement for that. So if you had thyroid cancer and you have to remove your thyroid, or if you have hyperthyroidism, Graves' disease, that's what hyperthyroidism is, then you need to, one of the treatments is to destroy the tissue with radioactive iodine. So what is that doing? It's destroying the thyroid tissue, so then you become hypo because it's not going to work, and so you have to take medication to replace it. In adults, it's insufficient secretion of TSH and TRH, which we talked about in the pathophysiology slide. All right. So how are we going to treat this? We're going to do replacement therapy. There's really not any lifestyle changes you can do other than treat symptoms that have already happened, such as weight gain. But as far as treating hypothyroidism, the treatment is lifelong replacement therapy. Usually, 99% of the time, patients get levothyroxine. I don't think, actually, to tell you the truth, I've never seen the T3 replacement because T4 is the mainstay. That is what your thyroid is making. If it's not producing it, you need to replace it with levothyroxine. And you stay on it for life. Thyroid hormone preparations. So I talked about already, it's a synthetic form of your thyroid. That thyroxine, which is T4, and it's the drug of choice. The half-life of it is 7 days, and it's used for all forms of hypothyroidism. You look in your med book to decide how you're going to dose that, but usually the motto, again, is start low and go slow. So if you have an elderly person, you want to start them on an even lower dose than an adult. Children, you would start on a lower dose. Children can get hypothyroidism. It's usually a genetic reason why they get that. If you look up the levothyroxine, you'll see they're all different colored pills at each dose, and they start in steps. So, and they're kind of odd doses, like 33, and they come in micrograms. So you have like 50 micrograms, 75 micrograms, 88 micrograms, 100 micrograms, and it goes up from there. So usually we'll start people on 25 or 50 micrograms and see where they are, and then we'll check them in about 6 weeks. All right, so levothyroxine should be taken in the morning at least 30 to 60 minutes before breakfast. So the reason being is, number one, you need to take it on an empty stomach because it interacts with a lot of medications. And number two, they just have you have a good night's sleep and then you get up and take it in the morning. There's no other reason other than you need to take in the morning after sleep, get up. I tell them to keep it at their bedside, take it, and then don't eat for at least 30 to 60 minutes before you're eating. Because of absorption, it's best absorbed that way on an empty stomach. Okay, so levothyroxine, these are the preparations, drugs that reduce the absorption, drugs that accelerate the metabolism, warfarin, and catecholamine. So these are all drug interactions. And there's many medications out there that can cause an interaction, so that's why we have them taken on an empty stomach. There are some medications where you have to say 2 hours before, 2 hours after. Drugs that, let's talk about the warfarin. Warfarin, the Coumadin, that's the brand name, is is a blood thinner for people that have atrial fib or a blood clot in their leg, or they've had some cardiac issues or blood clot in their lung, that kind of thing. Warfarin can actually mess up the levothyroxine absorption, as well as mess up your INR level being on the warfarin, meaning that your blood will get too thin or too thick. So during pregnancy, it's really important to make sure that you're treated during pregnancy, because if you don't, then they can have permanent psychologic deficits. Infants, it may be permanent or transient. It can cause mental retardation, derangement of growth. So that is one reason why prenatal care is very important. If anybody's hypothyroidism, they cannot skip a dose. They need to have their TSH monitored throughout their pregnancy and make sure they're taking their medications. Before I go to hyperthyroidism, I want to talk about hypo just for a minute here. So you're taking the levothyroxine because you want the T4, and you're taking T4 basically because you want it to start working again and get within the normal range. So how you're going to do that is they're going to take it, you're going to start with the lowest dose, and it takes 6 weeks. It takes a good 6 weeks for you to get an accurate level, TSH level and T4 free, to determine whether that dose is the right dose for that person or not. So they can't take the medicine and then have them come in a couple weeks, because it's just not going to be accurate. So wait a full 6 weeks, get the blood drawn. If your TSH is within normal range, your T4 is within normal range, then you can go ahead and continue at that dose and recheck it. If it's not, then you'll have to make adjustments to the dose. Some people are just so sensitive that we have to end up saying, all right, take the 50 micrograms Monday, Wednesday, Friday, and take 75 on the other days. So sometimes it can be very tricky to get people's doses how they should go. So just remember that if inpatient, the one thing that you really need to remember is they really need to take it at 7 o'clock or whatever time that they're having you take it, because it needs to be done on an empty stomach. Look at their other medications that they're on. And just know, usually you won't make any changes inpatient on your thyroid medications. All right, so hyperthyroidism, Graves' disease, and Plummer's disease. We see Graves' disease more often. It's the most common one that we see. And if you can see these bulging eyes, that's called exophthalmos. And not everybody with Graves' disease gets that, but a lot do. And it's like a hallmark symptom. If someone has that, you're like, oh, I wonder if they have Graves. Oh my gosh. So usually it'll affect women between 20 and 40 years old. Plummer's disease is a goiter, if you see down here. And notice that she's from a different culture, and most likely from another country, most likely an underdeveloped country, because those people are iodine deficient. They don't get it in their diet, and we need iodine for our thyroid to function properly. And so it's very prevalent, these goiters, in underdeveloped countries because of the lack of iodine. Now when you think of hyperthyroidism, it's hyper. Everything's going out of whack. Everything's hyperactive. Let's see, you're hot all the time. You're having tremors, tachycardia. So read through this yourself, but the most common one I see is tachycardia. Some people lose weight, although it can increase hunger. So I haven't always seen weight loss, but think that weight loss. When you think hyper, think everything's hyperactive. Hyperthyroidism is causes from thyroid stimulating immunoglobulins, so it is an autoimmune disease. The treatment there's different types of treatment you can do. So either you remove the thyroid tissue, which is usually, if you have a goiter like the one we saw in the plumber's disease, yes, they would do that. Or you do the destruction of the thyroid tissue, that would be with the radioactive iodine. Or you want to suppress the thyroid hormone by medications. So that's a step approach. So usually if somebody has Graves' disease, we try the medications first, which is the Tapazole, Methimazole. Then if that's not working, or if you have an allergic reaction to those medications, we think about doing the radioactive iodine. If all else fails, then you can surgically remove the thyroid tissue. But remember, thyroid tissue can grow back, especially if it's hyperactive. Okay, so thyrotoxic crisis is a thyroid storm. Patients with thyroid toxicosis who undergo significant stress, surgery, illness, it's not triggered by a rise in the thyroid hormones. It cannot be identified by laboratory testing. It's basically people that have gone through a lot of stress and it throws off their thyroid hormone, and it comes on pretty suddenly. Okay, so I had mentioned in an early slide that the thyroid storm was hypo. It's not, it's hyper, so I apologize for that. We don't see a thyroid crisis or storm, so the crisis would be if it's too low. We don't see that. It's very rare because now, especially in our developed country, we have the medications and the health care for people to have access to get treated for it. All right, hyperthyroidism, Methimazole. It's the first-line drug for hyperthyroidism. It does not cause the liver damage associated with PTU. So PTU used to be the old drug, although PTU is given for people that come in with a thyroid storm or crisis, because that's the one that will work the fastest and it's made IV. But you have to watch the liver because that can be dangerous. So Methimazole is the most common one. PTU is second line. PTU also comes in oral form. It does not destroy the existing stores of thyroid hormone. May take 3 to 12 weeks for this drug, and it's more dangerous than PTU during lactation during the first trimester of pregnancy. You don't see it too much during pregnancy. What you'll see a lot is people having either hyperthyroidism or inflammation of the thyroid post-pregnancy. So 4 applications in hyperthyroidism. Sole form of therapy for Graves' disease. Remember, Graves' disease is a form of hyperthyroidism, the one where you get the ophthalmos, the eyeballs sticking out. It's an adjunct to radiation therapy until the effects of the radiation start working. It also suppressed the thyroid hormone synthesis in preparation for thyroidectomy. And patients experiencing a thyrotoxic crisis, although PTU is preferred, which I mentioned that before. Now we have PTU. Again, it inhibits the hormone synthesis. It's second-line drug for Graves. Short half-life, about 90 minutes. Full benefits take 6 to 12 months, so it takes quite a while. It's used for Graves' disease, again, an adjunct to radiation therapy for the thyroid, in preparation for surgery, and then the toxic crisis. PTU was the first drug to come out on the market for hyperthyroidism, but then they developed Methimazole, which had less side effects, so that's why Methimazole now is first line. The PTU is second line. So to kind of narrow things down and to put it in your head better, think of hypo is levothyroxine, hyper is Methimazole, PTU, radioactive iodine, or surgical removal. All right, so those are the 4 treatments. If you're over here with hyper, eventually you're probably going to go hypo. And then eventually we'll need levothyroxine, because if you're destroying the tissue, then you're going to eventually need levothyroxine. The only time over here that you'll continue with hyperthyroidism and not need the levothyroxine is if you're using the medications, because it does not destroy the thyroid gland. One thing to really know about PTU, methimazole, is the most common side effect is a rash, and it's actually a pretty high prevalence. That's why a lot of people don't tolerate these medications. If you have methimazole on board and you have a rash, they'll try switching you to PTU, but again, the drugs are kind of very similar in a lot of ways, so it's a high prevalence of rash in PTU if you've already had a rash with the methimazole. Alright, so more comparisons of the two. PTU can cause severe liver injury, which I mentioned before, and methimazole, you don't have to worry about that. PTU has a shorter half-life, remember the 60 to 90 minutes versus 6 to 13 hours with the methimazole. So that's why it requires 2 or 3 daily doses rather than 1. PTU crosses the placenta less readily than does methimazole, and achieves lower concentrations in breast milk. So that's a plus for PTU, right? And PTU blocks conversion of T4 to T3 in the periphery, whereas methimazole does not. So in the periphery, meaning in other areas of the body. So T3 is in other areas of the body. So if PTU, you have to keep in mind that T3 may be blocked and not made into the other areas of the body, such as cardiac tissue and things like that. Alright, so let's go to the third line therapy after, well, let's say second line after you tried the medications. So it's basically radiation, radioactive iodine. It's an isotope of stable iodine. It emits gamma and beta rays. It's just like radiation. The half-life of it is 8 days. It takes 2 to 3 months for the full effect, and it's used in Graves' disease. Alright, so once they do the iodine, it takes 2 to 3 months for full effect, so usually after that they'll start checking your thyroid. And what's going to happen is you're going to see that TSH go higher, 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 because then you're going to be hypo, right? So now your anterior pituitary is telling the thyroid, wake up, wake up. So that TSH is going to go up because it keeps secreting more and more to wake it up, because you just killed off the tissue. This looks like the radioactive isotope 131. Yeah, it's the same thing. Like, huh. Okay, so we talked about that. All right. So it produces clinical remission with destruction of the thyroid gland. The one thing, now this is good that beta blockers are brought into this. It's going to bring down your tachycardia that you have. So again, as I said before, the most common symptom people have is tachycardia. Someone comes in your office, you suspect hyperthyroidism without getting labs drawn yet, you need to treat those symptoms. So you put them on a beta blocker right away. So if you're going to radioactive iodine, you should probably have already been diagnosed with hyperthyroidism. So this patient should already have be on a beta blocker. You put them on it right away in the office. I mean, it's an awful feeling to walk around with tachycardia, and you really want to treat those symptoms. Because remember, everything's hyper. Non-radioactive iodine. It's a strong iodine solution called Lugol's solution. This is only used in preparation to suppress the thyroid in preparation for a thyroidectomy. There's some adverse effects to it, such as it tastes brassy, which I'm not really sure what brassy tastes like, but anyways, brassy taste. A burning sensation, soreness of your teeth and gums, a headache. You can get a runny nose, salivation, various skin eruptions. I personally have not had experience with Lugol's solution, but just remember this is not radioactive, and it's used in preparation because you can still suppress the thyroid with this iodine solution, and it's for thyroidectomy. You do not want to give radioactive iodine because if you're going to remove the thyroid, you're going to expose radiation. So you don't want to do that. Once you have a radioactive iodine, usually you cannot go back and get a thyroidectomy. And obviously if you have thyroid cancer there after that, then that would need to be addressed. It's no different than prostate cancer and they put seeds in. You can't go in later and do a prostatectomy because of the radiation exposure. So beta blockers, which we talked about already, I seem to jump ahead. I just didn't know what the slide was. So it can suppress tachycardia and other symptoms. and the benefits derive from beta-adrenergic blockade, not from reducing levels. So it has really nothing to do with you suppressing or reducing levels of T3 or T4 in the thyroid. It has to do with the beta-adrenergic blockade in the heart. So it's reducing the workload of the heart, therefore reducing your heart rate, which tends to go up with hyperthyroidism. If someone's in a thyrotoxic crisis, they're going to have tachycardia. All right, so that's the end of the slide set. So keep in mind, with hyperthyroidism, you're going to be hyper. They're going to be irritable, nervous. They're going to have some tachycardia. Let's say their eyes are bulging out. What are you going to suspect? Are you going to suspect hypothyroidism? No, you're going to suspect hyper. And the hallmark of the exophthalmos with the eyeballs sticking out, it's easier for me to say that, then you're going to think Graves' disease, okay? The one thing, too, about methimazole, so for Graves' disease, you can start first-line methimazole. There is a rare, although adverse reaction that needs to be monitored, and that's called agranulocytosis. So that has to do with your white blood cells and the differential of your white blood cells, your granulocytes. So what are white blood cells? White blood cells fight infection, right? Then you have your differential, which would be your lymphocytes, your eosinophils, SEGs, your lymphocytes. There's also granulocytes. All those have to do with your immune system. So methimazole has known to mess up your granulocytes, meaning it can suppress your immune system. So if someone's on that, you really want to monitor for infection. So what you would do, a good teaching tool for them is you would tell them, you know what, let me know if you start getting a sore throat or sick with a respiratory infection or any type of sickness. I would have them come in and see you. Because you want to monitor that anyways with the CBC with differential. The other thing to remember is that since you'll be most likely working inpatient, or if you're in an emergency room, if somebody comes in and they are hyperthyroidism and they have symptoms of a thyroid storm, then what are you going to give? Let's just say their TSH is barely functioning and they're having a lot of symptoms of hyperthyroidism. What's the best thing to give? Which I mentioned on my slides before. There's the medications, but you would give PTU because you probably want to give something through the IV quick to get things going. And in an emergent situation that's life-threatening, you're not going to worry as much about the liver stuff. You're going to give them PTU through the IV. Because remember the short half-life, and remember the other one, methimazole, it has a longer half-life, and the first-line therapy for treating long-term hyperthyroidism. And then another thing to remember about hyperthyroidism, when you're giving the radioactive iodine, remember what the drug is actually doing. It's destroying the thyroid gland, or actually destroying the cells in the thyroid gland to reduce hyperthyroidism. All right. So as far as taking that, they usually will go into the office and they'll take, it's like a drink type of thing. You take the radioactive iodine, you go home, you still can be around your family. You'll have to be so many feet away from your family, meaning you won't be able to be in close contact for a few days, although they can still be in the same house. You just have to stay away. Don't be giving your kids hugs or anything like that, because it takes 2 to 3 days for that part to wear off. Oops, sorry, I hate when I get these emails when I'm taping. Okay, and then the other thing is it's just a one-time dose that you're taking, and trying to think what else with that. Oh, like if you have to use the bathroom, usually you have to double flush just because of the radiation. So that's about it on that. And then lastly, one thing I'd like you to try to practice is getting to know how to diagnose hyper and hypothyroidism, meaning the TSH, T4, and T3. So what if the TSH is elevated? So let's just say normal, which I'm going to write down here. I'm always writing my thoughts down. Let's just say normal is 0.5 to 5. 0.5 to 5 is your TSH normal levels, and it's supposed to be that. And then you have your T4, which I can't really remember the levels of that. Let's just say it's 2 to 3. Okay, we'll just do that. And let's just say your TSH is, you get it, your patient comes in, I've been really tired lately, just not feeling well. All right, let's get a TSH. And let's just say the TSH is 15. So I'm looking, it's past 5, right? 0.5 to 5. So your TSH is elevated. So what does that tell me? Are they hyper or hypo? So those are the things I want you to try to understand. The TSH is high, so that means they would probably be hypothyroid, because the thyroid stimulating hormone is stimulating the thyroid to work, so it's going to secrete more stimulating hormone to get it to wake up. And your T4, let's say, is 1, so that's low. That tells me, that verifies for me that you have a hypothyroidism because your thyroid hormone's not producing. So that would make sense as it's going back up to the parathyroid hormone in the hypothalamus. And then an opposite for the hyperthyroidism. There is some subclinical hyper and hypo, meaning like say 0.5 to 5 is normal and your TSH is 7, but your T4 is normal. So it tells me, I don't think I'm going to put you on medications now. You're kind of on the border of it. You're borderline. So we're just going to monitor those levels. All right, and that is it on thyroid.